All right, great to have everyone here. Let's, I think we are pretty close to a little past our start time. So Ella, are we ready?
Good to go.
Okay, and then I think Dr. Garcia is ready. So I would just, again, want to say good morning, good afternoon to all of you. I want to thank you for joining us here for the American Indian Alaskan Native ATTC ESAS webinar. Today we have the topic of treatment knowledge. I know that Dr. Garcia is going to cover a lot of information, so get out your sponge mode and be ready to soak some of this up. I do know, having done some of these myself, that for some of you this may be a review, and for others this may be something you're hearing about or learning about for the first time. Either way, it should be very informative, and we're really happy to have you here. I've just got a couple of slides I'm going to go through before I turn the floor over to Avis Garcia for today's webinar. But again, I have Ella Driscoll on the line as well. She'll be here for a little bit, and then she's going to sign off, but she's here to get us started. Again, thank you all for being here. As you know, as many of you know, this training series is brought to you by the National American Indian Alaska Native ATTC. We are part of the ATTC network. We are broadcasting to you now from the University of Iowa in Iowa City, Iowa, and I believe Avis is broadcasting to you from somewhere in the tropics. No, I think she's in no, not Flagstaff. I can't remember where you are.
I'm in Cheyenne, Wyoming.
Cheyenne, Wyoming. Yes. I don't know where I got Flagstaff, but again, this project, today's broadcast, is supported by SAMHSA. That is our funder. The content of this presentation today is developed by the presenter, and the opinions expressed today do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian Alaska Native ATTC. Following today's webinar, just so you know, we do offer a CEUs for this particular webinar. If it's a 90-minute webinar, I believe we can offer 1.5 CEUs. So if that's something you're interested in, please, when you get your follow-up email, you can make that request to myself, to Ella, or to anyone at our center, and we will make sure you get your CEU certificate. So in the next couple of days, you will get a follow-up email if you attended. This will include a link to today's recorded event, as well as any handouts that Dr. Garcia makes available. And then the CEUs, as I mentioned, these are NADAC certified. So we are an NADAC certified provider. So they are NADAC CEUs, NADAC approved. We are currently waiving any fees for CEUs during the pandemic, so there's no charge for any CEUs following today's presentation. We will be giving a brief survey link today in the chat box, and we'll also make this survey link available in the follow-up to today's presentation to give you another opportunity. Please fill out the survey. It's completely anonymous. It just takes a few minutes, and it's really important for us to get feedback from you on how this webinar impacted you and whether or not you found it valuable to your own professional development. So please, your feedback is very important, and I think the dog agrees as well how important this is. So again, look for that email. You can request CEUs, and you'll also be made available the documents connected to today's webinar. As most of you know, you will be muted for the duration of today's presentation. Utilize the chat box or your hand raise feature if you would like to speak or have a comment or question. I think Dr. Garcia and I sort of agreed that we can either maybe answer a few questions as we go, or perhaps leave a little time at the end to do a Q&A. So let's kind of see how this goes. We want to make sure that she's able to get through all of her information, and that we also provide an opportunity for us to answer some questions or address some comments. So, so with that, I want to introduce my friend and colleague, Dr. Avis Garcia. She is a PhD, LAT, and an LPC. I told her that if she gets any more letters behind her name, we're going to have to get another page to her bio. So that's it. No more, Avis. As she said, she is in Wyoming, Cheyenne, Wyoming, and she really comes to us with almost 20 years of experience working in the addictions field. We're really happy to have her here. She is an enrolled member of the Northern Arapaho Nation and affiliated with the Eastern Shoshone Tribe of Wyoming. She's got a lot of information to share, and I don't want to delay any more than I have. We're really happy to have her here. So I will turn the floor over to Avis and enjoy today's webinar. Thank you.
Okay. Good morning or good afternoon, wherever you're coming from. As he said, I am in Wyoming, and I am from the Wind River Reservation, and like they said, I'm Arapaho. My mother was Arapaho and my father was Eastern Shoshone. So I'm both tribes that reside on the Wind River Reservation. And we'll go on ahead and get started here. To the slides. Okay. My slides aren't. Okay, there we go. Sorry, get caught up. Okay, today's objectives will be to cover.
We can't see your screen.
You can't see my screen?
Nope, but
okay.
If you just click the green button on the bottom of the Zoom toolbar.
Okay. Okay, I don't know what happened. That's what happened to me the last time. Sorry, people. I was seeing Steve's picture over my screen. Let me see if that works. Is that working?
No. Yeah, if you go into Zoom and there.
Okay.
That looks better.
Okay, sorry guys. I was trying to get this to where, okay, we're covering treatment knowledge today, and this is a series of webinars that we'll be presenting to help people that are preparing to sit for the addictions exam, whatever is required in the state that you live in. I know different places have different names for the different levels of certification. And this is a really good review for me as well as someone who provides treatment and teaches people about providing substance abuse treatment. So today's objectives will be to get a better understanding of what evidence-based practices, best practices, and promising practices are, a better understanding of the importance of having a treatment alliance, become familiar with commonly used evidence-based and best practice approaches, and better understand co-occurring disorders and integrated care, and also to explore medication-assisted treatment. Okay, starting with the evidence-based and best and promising practices. The evidence-based practices are methods or techniques that have documented outcomes, have an ability to replicate key factors, and have been recognized in scientific journals by one or more published articles. Evidence-based practices are often manualized. For instance, the SAMHSA Technical Assistance Publication Series called TAPS. Evidence-based is also based on extensive research, and a lot of them don't really address specific Native communities. So what seems to fit more for Native communities are the following: the best practice, a method or technique that has consistently shown superior results to those achieved by other means. In addition, a best practice will evolve as empirical research advances. Promising practice is generally described as a body of evidence to support efficacy or is likely to raise the next level when scientific studies can be conducted. And we often refer to our practices that we use on the reservation that I don't see really included in reviewing for this exam. For Native populations, we rely on a lot of our cultural practices that we combine with our treatment services. Characteristics of addiction. The ASAM, American Society of Addiction Medicine, the third edition, describes the characteristics of addiction as an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems of one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Okay, did I jump ahead here? Let's see. Okay. Sorry. Goals for treating use and co-occurring disorders: to properly assess the patient using multi-dimensional tools, to provide integrated, coordinated, longitudinal care using evidence-based approaches, to provide an optimum opportunity for healthy behavior change through a therapeutic alliance, to improve the patient's overall wellness and health, and to measure the outcomes, to provide informed consent with the individual, family, and community recovery-oriented systems of care. What does this all mean? We have a responsibility to improve service delivery and monitor patient outcomes. The field of addictions treatment is evolving and will require a broader understanding of the term treatment. We have a responsibility to stay informed about evidence-based practices, best practices, and promising practices. Those in leadership positions have a responsibility to prepare and mentor the next generation of addiction professionals. Beginning with a therapeutic relationship. And here's a quote by Steve Stein himself. The more we involve our patient in the decisions about their treatment process, the more meaning and purpose they will likely associate with their treatment experience. The therapeutic relationship is the therapeutic alliance that is developing rapport, common or shared goals, to obtain the safety and trust of the individual in treatment, ethical responsibilities, and power distribution. This needs to be a shared collaborative relationship with the individual that you are providing treatment services for. The therapeutic relation function is to provide positive reinforcement, encouragement, instill hope, and build self-efficacy, to provide the patient with support and accurate and genuine empathy and partnership with the patient, develop goals that are realistic, attainable, and adaptable, and to model adaptive interpersonal functioning. The therapeutic relationship, the patient development includes that the patient really feels that they're being heard, that you understand them, that they're accepted, respected, and empowered. Feels that the therapist is concerned, feels that the therapist is working with them and not against them, feels that the therapist is realistically optimistic, feels and recognizes that positive change is possible and are occurring. This is the ASAM criteria. This is the third edition. It is a clinically driven program, not program-driven criteria do not involve a prescribed length of stay, but promote a flexible continuum of care, involves an interdisciplinary approach to care, includes informed consent, are outcomes driven, and clarify the medical necessity. The continuum of treatment care of the ASAM criteria allow for a broader continuum of care, differentiate between adult and adolescent care, and a common set of criteria that also helps to determine the client's level of severity and place the client in an appropriate level of care, LOC. The ASAM levels of care are level 1, which is outpatient treatment, and that varies from different treatment agencies as to what that entails. Our outpatient treatment where I work, our level 1, we give them an option of they want to meet with someone individually, or if they would like to attend a group for outpatient care. And when they attend group, we usually have them attend 12 to 10 sessions. And that is also the same for individualized. We give them the option to choose if they want to go to group or if they want to be with someone individually at a level 1. The level 2 mostly involves intensive outpatient treatment and partial hospitalization program. So again, states differ on what the requirements are. Here in Wyoming, most of the programs require 120 hours of direct patient contact and treatment participation by the individual. And Colorado is our neighbor, like about 30 minutes from here, and their recommendations for that level of care are a lot more intensive than ours are. So sometimes we get people that are willing to drive all the way over here because we don't have them do as much as Colorado requires. Level 3 is medically monitored inpatient treatment, residential treatment, and there are about 3 levels to level 3. There is a 3-1, a 3-3, and a 3-5, and it just depends on that individual's needs and their severity of their treatment. Level 4 is the medically managed inpatient residential treatment. And this is often recommended for people who have severe medical issues that are occurring in their life because of their long time substance use. This may be someone struggling with brain damage, or maybe they have cirrhosis or any other medical problems that could be caused by their use. The dimensions of ASAM include, there are 6 dimensions. So the first one is the acute intoxication and withdrawal potential. Biomedical conditions and complications is number 2. So any medical problems we might be concerned about, we want to evaluate those. Third is your emotional, behavioral, or cognitive conditions and complications. And these are rated on a scale of 0 to 4, with 0 being no problem, are stable, 1 is mild, 2 is moderate, 3 is substantial, and 4 is severe. So you assess each level using that scale. And 4 is the readiness to change. Where are they? Are they aware that they have a problem? Or are they really ready to get help? Like I said, most people that come to treatment don't readily volunteer themselves to attend. 5 is the relapse, continued use, or continued problem potential. So we want to know what kind of environment they are exposed to. Are they in an environment where all of their associates are users as well? Or do they have a stable home environment where people aren't using, so that we know we can send them home to a safe environment? And number 6 is also the recovery living environment, which also looks at where are they going and who are the kind of people that they're hanging out with, what's available to help them have the support that they need to be successful. And I'm often asked by people how to use this ASAM criteria and I like this little walkthrough chart because it has all of the levels of criteria across the top and off to the bottom. So above the top, it covers the levels of care. And then on the left-hand side, we have the dimensions 1 through 6. So it gives you a written description of what you might be looking at to rate that person. And I've attached this document as one of the handouts because it's a really handy dandy thing, especially for people that are new in the treatment field and recommending a level of care to someone. And this is the second page of that crosswalk that covers the other 2 dimensions. It can also be used as part of your assessment by putting the treatment level, the recommended level, and the clinician can sign off on this as well. So this is something you can use for your own practice. One of the popular treatment approaches is the whole person patient-centered care. It is an established therapeutic alliance that begins with the patient's initial contact with the helping professional and organization. Proper treatment requires proper assessment. The ASAM is commonly used as a multi-dimensional assessment tool, and most places require it. Whole person patient-centered care is a multidisciplinary team approach using community support systems. Selecting a particular theoretical approach that is most likely to result in the patient's improved health. Patient-centered therapy is an approach in counseling where the client, not the counselor, directs the treatment process because he or she is capable of invoking change within him or herself. And my agency is CARF accredited, and it's an international accreditation, and the state of Wyoming requires us to be CARF accredited to receive any funding. And CARF requires us to use this person-centered care. That has to be a big part of treatment. Person-centered therapy was created by Carl Rogers in the mid-1940s. And this therapy does not have to revolve around the therapist's advice, direction, or interpretation. The client uses their own understanding, self-realization, and problem-solving techniques. The counselor or the helping professional comprehend how the client sees themselves in the world. So oftentimes when we're doing that treatment plan, we let them give us some guidance of what it is they would like to do, what they would like to do to direct their own treatment. The main principles of person-centered therapy involve humanism, which is the innate nature within all humans to achieve our potential and find meaning in life. Congruence, that the counselor is genuine or real. Unconditional positive regard, that the counselor shows constant acceptance and caring. Accurate empathic understanding, identify with and understand the client's subjective world, which assumes there is a basic trust to be found in the client's ability to move in a positive direction if the right elements are provided by the counselor or other helping professional. Some counseling theories and practice. Theoretical-based approaches are concrete methods for assessing and conceptualizing individual conditions. Assist in increasing their motivation to effectively follow a path to successful recovery. No one approach is appropriate for all. Everybody's different and they all have their own unique needs that we have to be mindful of as we work with these people that need help. I like to refer to this as the theoretical tool bag, where we select the best tools for the job at hand. On a final note, it is important to emphasize that very few counselors can be adept at all of these approaches this section covers. However, by developing skills with several of these that best fit the counselor's philosophy and level of comfort, one can develop an integrative approach to counseling. Some evidence-based practices include behavioral theory by Skinner, Cognitive behavioral therapy, often referred to as CBT by Beck. Contingency management and incentivizing. Screening, brief intervention, and referral to treatment as the SBIRT. Rational emotive behavior theory by Albert Ellis. Motivational interviewing by Miller and Rolnick. Stages of change and trans-theoretical model by D. Clemente. And more recently, a lot of focus has been on the medication-assisted therapy. Starting off with behavioral theory, some constructs to consider is that all behavior is learned. Therefore, it can be unlearned. New behaviors can replace old ones. Focus on the observable, how people act, react, and behave. Is less interested in the cognitive and emotional states. Believe that the behavior represents learned habits. It is an action-oriented form of counseling to promote behavioral change through techniques of conditioning, originated in the 1950s with applied principles of classic and operant conditioning. The Roots of Behaviorism by Ivan Petrovich Pavlov, John Watson, and B.F. Skinner. The behavioral theory conditioning has two components of the classical conditioning, which refers to the association between the stimulus and an involuntary or automatic response. A craving can be conditioned response triggered by stimuli that the patient may or may not be conscious of. Operant condition refers to association between a voluntary behavior and a consequence. The nature of the consequence will impact whether the behaviors occur again, such as legal consequences, health-related consequences, job-related consequences, family consequences. Behavior therapy key concepts by Pavlov, Skinner, and Bandura includes classical conditioning, operant conditioning, and social learning theory. I included this picture here because this basically comes from Psych 101, or your very first psychology class you might ever taken in college. And it's a particular response to stimuli that can be elicited over time by association with a repeated stimulus, which is a method of counseling that focuses on modifying the client's learned behaviors that are negatively affecting their life. It's extremely effective for clients in recovery from psychoactive substance use disorder, since there are specific learned behaviors and triggers associated with drug use. So if you look at the picture here, the bell ringing and the food for the dog causes them to salivate. So over time, we remove that stimulus. And so when the bell is rung, the dog automatically begins to salivate. So that is the classical conditioning. Motivational incentives to use. This is a proven approach to treatment. It looks at motivational incentives and contingency management. This is where we're promoting awareness of motivational incentives. It's an introductory training that exposes organizations to the principles of motivational incentives and demonstrates evidence of clinical effectiveness. Behavioral health care practitioners can deepen their knowledge about the motivational incentives through participating in the free self-guided interactive online course. And I believe we have the link included in here in the next page to this, and it's online and it's free. It's more commonly used in adolescent treatment. It's been proven to improve treatment outcomes. Research shows it improves treatment from 43 to 70%. And that is providing reinforcement for healthy behavior. It promotes, the PAMI is promoting awareness of motivational incentives. And here's the website where you can log in and take that free class if you're interested in doing that. On some level, we kind of offer, I oversee a drug court program, and we do offer incentives at different levels of care. They get coins for 30, 60, 90 a year of sober time. They get gift cards, and when they graduate certain levels of our program, we give them little gift bags with little things that, you know, they don't have to be very expensive, but like I said, they seem to work really well with adolescents. Why would we use motivational incentives? Because it helps the patients to stay in treatment and to abstain from drug use. Using low-cost reinforcers, prizes, vouchers, praise, and not as bribery, but for recognition. There are fish bowls where you can put tickets or little cards in there of little things that they can earn. Tickets for prizes such as notebooks, pens, a small book, planners. And this is doesn't always have to be something that is focused on having them receive actual things, but even just getting a clean UA is really positive reinforcement. And that's a lot of what I like about the DUI court program that we work with, because they get a lot of praise and recognition from important people that run the program. Cognitive behavioral theory, CBT, combines behavior therapy, which helps to weaken the connections between troublesome situations and the reactions to them. Cognitive therapy teaches how certain thinking patterns and feelings impact behavior. Simply put, CBT attempts to help patients recognize, avoid, and cope. So I like to think of CBT that helps patients connect their thoughts with their behavior and increase their awareness to promote positive change. A lot of times they've learned certain things the way they were growing up in the environment they were raised. Example, I had one individual who told me that he never talked to a counselor before because his dad told him that nobody wanted to hear his problems. And so we were able to work with him and getting him to realize that that's what we do. That is our job. Our job is to listen most of the time. And it's taken him time, but I often remind him that he has shared that information with me about where he learned a lot of his thinking from and keeping things to himself. CBT has been proven to be effective for relapse prevention. It helps patients to identify high-risk situations, commercials, bars, parties, weddings. There are a lot of events that we like to have our clients let us know ahead of time so that we can have them come up with a plan of how they're going to address that. So then that comes, the coping skills comes in. Are they going to leave? Are they going to call someone? Or what other methods do they have? It enhances their own self-efficacy. They feel really good about themselves when they're able to do it successfully. Relapse is also reframed as a teachable moment. And a lot of clients that I've seen over the years can be really hard on themselves when they relapse. And some of them, they just drank that one time and they self-report, and I'll let them know, hey, you stopped, you didn't keep on going, and you're doing the right thing by coming here and letting us know what happened. And it's to challenge positive alcohol expectancies and to add lifestyle balance to their life. Some key concepts. The founder is Aaron Beck. The focus is on the here and now, not on the past or in the future. We want to be present focused. The client takes an active role, and it uses the ABC model. Some therapeutic techniques involve some behavioral rehearsal, homework, motivational interviewing, relaxation training, systematic desensitization, social skills training, and assertion training. They need to be able to say no and walk away from situations that aren't conducive to their recovery. The next one here is REBT. It's a cognitive-oriented counseling approach that focuses on changing the attitudes, beliefs, and negative self-statements that drive and maintain problematic behavior. This is created by Albert Ellis in 1955. Rational emotive behavioral theory, REBT, in a nutshell, is something that happens to the patient. Patient has an irrational belief about the situation. The patient has an emotional reaction to the belief. The therapist helps the patient recognize errors in thinking that led to the irrational belief and find alternative ways of thinking about the event. An example here in quotes is, "I was arrested for drunk driving because that cop had it out for me." Lots of times it involves their relationship. Well, me and my girlfriend got into a fight, or my boss made me angry. And so their way of coping has been using, so it's been trying to help them to learn other ways to manage those emotions when they have them that could trigger use. REBT includes the ABC model. A is the activating event, events that occur in life that leads to a reaction. B is beliefs, how the person feels or thinks about that activating event. C, emotional and behavioral consequences, how the individual behaves based on their beliefs concerning the activating event. Overriding principle of REBT is that events do not disturb people, but rather the view individuals take on the events that lead to dysfunction. And here is the stages of change model by Prochaska and Di Clemente that starts out with the pre-contemplation. They're thinking, maybe I have a problem. And this doesn't just apply to substances. This could be to any kind of addiction that we apply this to. And then there's the contemplation and preparation. So maybe they start getting ready to quit smoking, and so they want to find what they can do to help themselves come up with a plan. Then there's the action stage, and there's also the maintenance stage. So once they've established recovery for a significant amount of time, the program that I oversee, the treatment program, is approximately a year long. We have our aftercare runs from 6 to 9 months. And then there's also the relapse and recycle. So not everyone is successful. I would say there's maybe a 50-50 chance that some get into recovery and stay there, and some, they really struggle a great deal. So it just depends on what level of care you have them in. And a lot of times we have to reevaluate that when they're not doing so well. And it doesn't always mean that everybody has to go into residential treatment. I often see a lot of clients and they often think I'm sending them to residential treatment until we explain that there's different levels of treatment involved. So that sometimes we do get people that need residential treatment, but there aren't any openings. Here in Wyoming, there aren't very many residential treatment centers. So oftentimes we put them into a lower level of care while we wait for them to get a bed. And by the time they get a bed, some of them are doing well enough. So we'll table that for future use if we think they still need it. Motivational interviewing is a way of being with people when its underlying spirit lies in understanding and experiencing the human nature that gives rise to that way of being. How one thinks about and understands the interview process is vitally important in shaping the interview. Motivational interviewing was originally developed in an effort to increase motivation of patients with alcohol problems to change behavior. As part of the process, Miller found that approaching patients with a modified patient-centered approach increased the impact of the interview. What has evolved is a communication style and focus that increases patients' motivation to work on the problem. And this is the cover of the book. If you're interested in that, it is a really good book. It's one that I refer to quite often. Motivational interviewing is a fundamental approach. It's a collaborative approach that evokes and suggests what could they do differently, or maybe some people are not real willing to go into treatment, and so you want to focus on, well, what is it, why do you not want to go? And they're like, well, I want to get my wife off my back, or I want to get my probation officer off my back. So, well, what does that involve? What do you need to do for that to happen? So once they realize that they really need to apply themselves to their treatment, they'll start to take some action. 4 principles are to express empathy, not sympathy. So like, I understand that sounds pretty difficult, and to develop discrepancy, to find out that that's not always, they're not always up against a wall or facing a negative situation, and then to roll with their resistance and support their self-efficacy. Let them to increase their own belief in their ability to take care of themselves and be successful in establishing their own recovery. Clinicians commonly think they already practice motivational interviewing, though that's often not the case. What makes motivational interviewing a unique communication approach is how its constructs are employed by the clinician. Motivational interviewing requires attention to timing issues, specific strategies, application of methods, and maximizing the effectiveness of these skills. SBIRT is a screening tool used to assess patients' risk of having a substance use disorder. B and I are the brief intervention, consists of a 3 to 5 minute motivational discussion with the patient concerning the screening results. R is the referral to a specific resource for additional assessment and or treatment service. T is treatment. The treatment provider process should allow for a warm handoff from referral source to a treatment provider. And this is often used by medical professionals in emergency rooms and clinics. So when they see patients that they think might have a substance use problem, they may use this brief screening to see if they should refer the person to a treatment or a person to assess their treatment. Other theories worth mentioning. Did I lose the page? Okay. Social cognitive theory, personal factors, environmental influences, and behavior continually interact. People learn from their own experiences and from observing the actions of others. The health belief model helps to explain why people do or do not use preventive services, and it has to do with the perception of the reward or the risk. The social ecological model considers multiple influences on behavior and states that behaviors both shape and are shaped by the environment. Behavioral health care and substance use and mental health. Behavioral health is the integrated care, which you see includes the mental health, substance use disorders, if there's any other problems such as gambling, and primary care. The patient's substance use is not the problem, but rather a sign or symptom of other underlying issues driving the substance use. So it's not always the issue that it's their drinking, it's their coping method. And I often tell the patients, it sounds like you've been self-medicating yourself because you've been feeling depressed, or maybe they're dealing with post-traumatic issues and that's their way of escaping that situation. What co-occurring disorder means. In medicine, comorbidity is either the presence of one or more disorders or diseases in addition to a primary disease or disorder, or the effect of such additional disorders and diseases. The term dual diagnosis is often used to describe the comorbid condition of a person considered to be experiencing difficulties related to a mental illness and a substance use problem. What are co-occurring disorders? It's the presence of at least two. Sometimes there's 3 or 4. One being substance use disorders, the other being a DSM-5 mental health disorder such as depression, bipolar, schizophrenia, PTSD, or anxiety. So these are often treated in combination and not just one. Some characteristics of co-occurring disorders in general is a repeated cycle through treatment, emergency departments, detox, and jail. More likely to reoffend or receive sanctions when not taking their medication, they're not in treatment, they're experiencing mental health symptoms, or they're using substances. Use of even small amounts of substances may trigger recurrence of mental health symptoms. So a lot of these patients are already on medication that is helping to manage their psychotic episodes, their depression, or their anxiety. And so once they use those substances, it interferes with the effectiveness of those medications. And oftentimes they stop taking them because they think they feel fine. And then these other disorders that they have tends to flare up. General assessment of co-occurring disorders. ASAM dimensions can be used as a multi-dimensional assessment tool for co-occurring disorders. Assess the significance of the substance use disorder. So we want to obtain a longitudinal history of the mental health and substance use symptom onset. Analyze whether mental health symptoms occur only in the context of substance use, or are they substance induced? Determine whether sustained abstinence leads to rapid and full remission of mental health symptoms, but you will only know after the patient has been clean and sober for a period of time. The ASAM criteria affords the clinician an opportunity to identify a treatment plan and monitor progress for patients co-occurring substance use and mental health disorders. Characteristics of co-occurring disorders includes a more rapid progression from initial substance use to higher levels of severity, poor adherence to medication, decreased likelihood of treatment retention and completion, greater rates of hospitalization, more frequent suicidal behaviors, difficulties in social functioning, shorter time in the remission of symptoms. More characteristics continued would be difficulty comprehending or remembering important information, the verbal memory, does not recognize consequences of behavior, exhibits poor judgment, they're disorganized, they have a limited attention span, and respond better to patient-centered approaches. Some co-occurring conditions in adolescence. 90% of lifetime co-occurring disorder had one mental health disorder prior to the onset of substance use. And in adolescence is usually when the patient starts to realize that they're having some problems and they might not even be aware of what it is exactly. The median onset of mental health disorders occurs at the age 11, and the onset of substance abuse often occurs between the average age of 16 and 21 years of age. Evidence-based best practices continued. We are moving on to pharmacotherapy and medication-assisted therapy. Pharmacotherapy involves detoxification and withdrawal management, cravings for alcohol, replacement, aversive, antagonist and mix, agonist and antagonist. Medication-assisted therapy, MAT, is the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. This treatment approach has taken on new meaning considering the recent and increasing sense of urgency surrounding the opioid crisis that has gripped portions of this nation from coast to coast. Usually involves replacement medication like methadone, buprenorphine, or naltrexone to assist the patient in reduction of cravings, patient relapses, antagonists, and help stabilize often difficult and/or withdrawal symptoms associated with opioid use disorder. Medications for alcohol use disorder includes naltrexone, Vivitrol, which can be an injectable form of naltrexone and it's longer lasting. Disulfiram, also known as Antabuse, and acamprosate, Camprol. Several medications are currently being used in alcohol rehabilitation. Medications for opioid use disorders includes methadone. It is an oral liquid. Naltrexone, oral. Vivitrol, injectable form of naltrexone. Again, that's, like I said, it's longer lasting. Sublocade, it's an injectable form of buprenorphine. Suboxone, or Zubsolv buprenorphine combined with naloxone and Probuphine, buprenorphine implant. Several medications currently being used in alcohol rehabilitation. There's been a renewed interest led by the FDA and the approval of naltrexone in 1994 for the treatment of alcohol dependence. Disulfiram, or Antabuse, is a sensitizing or deterrent agent approved for the treatment of alcoholism of several years earlier, about 50 years back. Acamprosate, Camprol, has been available by prescription since 1985 in France and more recently in European as well as Latin American countries. Opioid and opiate, what's the difference? Opiate is the term that refers to drugs or medications that are derived from the opium poppy, such as heroin, morphine, and codeine. Opioid, a more general term that includes opiates, as well as the synthetic drugs or medications such as buprenorphine, methadone, meperidine, Demerol, fentanyl, that produce analgesia and other effects like morphine. These are often prescribed for pain. It is best practice to use the term opioids when referring to opioid use disorders. Some basic opioid facts. Description: opium derived or synthetics relieve pain, produce euphoria, and morphine-like addiction, and relieve withdrawal from opioids. Medical uses are for pain management and cough suppressant. Methods of use: intravenously injected, smoked, snorted, or orally ingested. Some are applied to the skin, such as the patches, and withdrawal prolonged is very unpleasant, but it's not life-threatening. A brief history of opioid treatment. The Drug Abuse Treatment Act of 2000 and the approval of buprenorphine in the United States Food and Drug Administration in 2002 for the treatment of opioid addiction Both allow for the expansion of traditional opioid treatment programs beyond the current structure to include treatment in office-based settings. With this expansion, more patients may be willing to access treatment, and the stigma associated with addiction may be reduced by broadening the definition and the location of treatment. So there are a lot of people that don't want to go to residential treatment. So there has been a great increase, often funded by federal grants, that provides medication-assisted treatment in the community setting. The opioid addiction continues to be a significant public health problem across the country. In 2007, approximately 12.5 million Americans ages 12 and older used prescribed medications for non-medical purposes, according to the National Survey on Drug Use and Health administered by SAMHSA. By 2019, full-scale efforts to systematically decrease the access to prescribed opioids medications over the previous decade have created a continual surge of overdose deaths and the ongoing use of heroin and fentanyl acquired illicitly in order to manage the addiction to these opiate-based medications, thus creating the epidemic we see cycling through our healthcare, substance use disorder treatment, and systems of care today. In 1964, methadone was approved. 1974, the Narcotic Treatment Act limits methadone treatment to specifically licensed opioid treatment programs. In 1984, naltrexone is approved, but has continued to be rarely used, approved in 1994 for alcohol addiction. In 2000, the Drug Addiction Treatment Act, the data expands the clinical context of medication-assisted opioid treatment. In 2002, tablet formulations of buprenorphine, Subutex, and buprenorphine and naloxone, Suboxone were approved by the Food and Drug Administration. In 2016, the first ever FDA-approved buprenorphine implant for opioid dependence, Probuphine. 2017, the FDA approves first once monthly buprenorphine injection, a medication-assisted treatment option for opioid disorder called Sublocade. Some myths and facts. One is patients are still addicted. The fact is, substance use disorder is pathologic use of a substance and may or may not include physical dependence. Physical dependence on a medication for treatment of a medical problem does not mean the person is engaging in pathologic use. Myth number two, the fact is buprenorphine is a replacement medication. It is not simply a substitute. Buprenorphine is a legally prescribed medication, not legally obtained. Buprenorphine is a medication taken sublingually under the tongue, a very safe route of administration. Buprenorphine allows the person to function normally. Myth number three, medication alone is sufficient treatment for opioid addiction. There is some research indicating that there is no difference in outcomes with patients receiving counseling in addition to medication. The fact is, buprenorphine is an important treatment option. However, the complete treatment package should include other elements as well, such as talk therapy and community support. Combining pharmacotherapy with counseling and other ancillary services may increase the likelihood of success. Myth number 4, patients are still getting high. Fact is, when taken sublingually, buprenorphine is slower acting and does not provide the same rush as heroin would. Buprenorphine has a ceiling effect, resulting in a lowered experience of the euphoria felt at higher doses. The advantages of buprenorphine in the treatment of opioid addiction: 1, the patient can participate fully in treatment activities and other activities of daily living, easing their transition into the treatment environment. There is a limited potential for overdose. There are minimal subjective effects such as sedation following a dose. It is available for use in an office setting. That's often the MAT, medication assisted treatment. And it also has a lower level of physical dependence. The advantages of buprenorphine and naloxone: it discourages IV use. It can prevent overdose deaths, naloxone. This summarizes everything that we covered here today. And we covered what evidence-based and best practice treatments were. Again, evidence is based on research, is often replicated, published in manuals, and best practices are things that we've used in treatment programming, and they are found to be effective, such as I was sharing our cultural practices that we often use on in treatment on the reservation. We provide sweat lodge as a big part of the treatment programming, and also encourage them to participate in communication with elders and other cultural practices that are specific to their tribe, and those are shown to be real effective. And the therapeutic relationship and treatment alliance. So it's real important to be genuine and authentic and show the people that you really care about them and their health and their recovery, using the best practices, being knowledgeable of co-occurring disorders. And there used to be a belief that, well, we have to treat their addiction before we could treat their other disorders that they're struggling with. So now we try to address those both on the front end, but sometimes those co-occurring disorders require them to be clean and sober for a length of time so that we can determine how that it was affecting their use of substances. And then we covered some pharmacological treatment options that are being increasingly used in treatment. And we often refer people to a couple clinics here in town that work with us to help these patients get the medication that they need to help them establish their recovery, mostly with the opioid use. And that covers everything, all the information today, and we'll open this up for some discussion and questions from the attendees.
Thank you very much, Avis. I really appreciated that, and it's a lot of information, I know, to absorb. But as I said earlier, it may be review for some, and for some, this may be information you're hearing for the first time. So I want to open the floor. There have been some comments coming through in the chat. A lot of observations and comments regarding the presentation, but feel free to unmute yourself if you have a question or want to place one in the chat box. We have a little time.
Scrolling through a lot of the comments to see what we have here.
I'm looking at them too, Avis,
Okay.
just to see if I can find one there was a good question maybe to put out there.
This is Dr. Foster. I am going to make a couple comments. There are many medication-assisted therapies which for coexisting disorders, independent of the ones that we mentioned, for example, gabapentins, Wellbutrins, for anxiety and depression, PTSD, and so forth, are also heavily diverted and misused on our reservations down to the middle school level. And so that doesn't mean they're not effective medications. It doesn't, but it doesn't mean always medication or never medication. But it does mean that we need to be, it's dynamic. We need to work very closely with the limitations and the present state of the people we're working with, because it changes, it shifts. And we've long known that addiction is not a 30-day program. And so the year program that she's presenting is just practical, because just if you have diabetes, just changing your eating habits. When our first child got diabetes, I thought, I'll help her because she's socially inclined. She doesn't like to stand out with peers. And so I knew that it'd be hard for her to change her diet at school. And she's a cross-country runner, volleyball player, very active athlete, sun dancer, sober, healthy young woman. Wow, of all of our kids to get diabetes, we didn't expect her. And I was going to change my diet. It was so tough because I could eat anything. I thought it would be easy to change my diet. Not so fast. And so our response to addiction is not much different than our response to diabetes, to cancer, to provider compliance with almost any condition. So I used to think we were failures as treatment providers. We're not failures. We're working with human beings. We're a species that takes shortcuts any chance we get, as do horses, as do pigs, as do deer, as do pronghorns, elk, you name it. Mammals look for shortest way to the water, and we do too. And if our primary goal is to not experience pain, then addiction is the shortest way. Do we have addiction becomes its own problem? But if we don't find other ways to manage pain, then we're going to find other ways to go to addiction. Okay, I'll be quiet now. And thanks so much for your wonderful presentation. And you were so comprehensive, and you covered so many areas that all I can say is in Washichu, amen. Okay, Doksha.
Thank you.
Thank you very much, Doc Foster. And I want to say Doc Foster is a consultant of ours and a member of our advisory council. We're happy to have him on the call today, along with David Natsaway, who is there in the audience, who's also a consultant and advisory council member. So Dave, good to see you. Glad to have you here today.
I see some people. Marilyn, you have a hand up.
I'm looking to see if I can find Marilyn. Yes, let's see if I can get Marilyn. Can you unmute if you have a question for Dr. Garcia, if you want to put it out there to the group?
Okay, incentives in treatment courts. Okay. We provide gift cards or candy, fishbowl choice. What makes the best incentive? How does the client know it is a special, and what is a good schedule for incentives? In the DUI court treatment program that I oversee the treatment component of, we have a 30, 60, and 90-day recognition in the courtroom where they're acknowledged by everyone in attendance. We ask them, you know, what's been working for you and what can you share with others? Of course, the COVID situation has created some challenging situations for us and how we were doing treatment prior to. We used to have all of our participants in the courtroom at once, and now because of the social distancing, we're bringing them in groups. So we often be like, darn, you know, we wish so-and-so could have seen, you know, some of our participants do well and don't use or violate any of the rules that we have throughout their whole program, but they are recognized with gift cards, again, at the 30, 60, 90, and year. And we do the same in the treatment programming. And when they complete like each phase of treatment, the first phase is their 2-1, their intensive outpatient. So once they complete that, we have a little party. Maybe we have some pizza or something. And then we give them a little gift. And then when they complete the whole entire treatment program, we often give them more. We recognize some of our participants for perfect attendance, for participation, any little thing that, you know, just to build up their self-esteem and their confidence is real important. And, you know, one method that wasn't covered here was the strengths-based perspective. And I tend to operate from that perspective of, you know, what strengths does this person have? What do they bring to the table that they can use to overcome those challenging parts of their life? And yeah, like I said, we have gift cards in like $10 amount and $20 amount, and then they often reduce their fines. They might owe 500, 700. So at every phase of successful completion, they get some of that fine taken off as part of an incentive. And lately, I also provide the DUI class as part of that specific treatment program. And so when I have people doing really well, I might give them a discount, be like, you know what, you have perfect attendance, you haven't violated any conditions of your probation. When you're ready to take the class, you can use this coupon to get $10 off your class or $20 off of your class.
That's, I think in the time of COVID, it's a lot more difficult, right? When we would have groups of people in the court and acknowledge their milestones, that, you know, the DA would be clapping, public defender, judge, and we would really make a point of it. And now, and people would be proud, and now no one's really seeing it. And we're delivering personally gift cards to people with peer mentors. But it's really only then 1 or 2 people saying, hey, good job, when it used to have the entire, they'd have everybody, you know, maybe 20 people supporting them. So I've been trying to think what would be the best way to say, hey, good job, and really encourage people and let them know that we value how hard they're working.
Mm-hmm. Yeah,
Thank you.
They work really hard, and any recognition helps them to feel good about themselves.
Dr. Garcia, Marilyn Begay has her hand up. I'm going to see if
Okay.
she can unmute and ask her question.
Hi, good afternoon. This is Marilyn Begay. I'm calling from Alamo Clinic, and I'm calling because I noticed that some 638s and IHS behavioral health services offer drug-related psychotropic medication.
Mm-hmm.
Just like what you mentioned, I was wondering how I can help, start it here in our department. And I know a lot of people are against it because they feel that it's addictive,
Mm-hmm.
like to offer addicted heroin users and meth users.
Mm-hmm.
to offer them an alternative with the psychotropic therapy and also counseling.
Mhm.
So I was wondering how I would go about, shoot, I'm going the wrong way. Go about helping this community out with starting that type of program.
I would suggest that you do some research and finding some programs that are currently operating and look at how they implemented them. I do know that there are some tribal opioid response grants that have been awarded throughout the country for people that have strategically planned to implement such a program. And here in Wyoming, the state, I believe, received some funding for the whole state. So bits and pieces of it are distributed out through the agencies here in town. And I fortunately have a friend who is the director of the mental health of a, like it's kind of like a non-for-profit medical clinic here in town. So we work in conjunction with each other. And so we provide the treatment and they provide the medication. So we check in with each other for those that we do put on that program. And it's educating the community just like this of this is not what it is. We're not getting them hooked on drugs. They're not getting the, the effects of the drugs and how these substances actually work on the brain to help them reduce cravings and for some of them to stop use altogether. And when we first started out, it was not very effective because a lot of the participants just wanted the medication and they weren't participating in the counseling. So we had to all come together again and reevaluate that whole situation with them on the front end of, this is a comprehensive program that's going to require, and for it to be effective, you need to be, attend your sessions regularly. And there's a lot of research that shows in combination that these work together. And very, there have been a few that I've seen do well that didn't do much of the treatment at all. And that would be their argument was like, well, I'm doing fine, I'm not using. And I'm like, you have a valid point, but the program entails working on certain issues in your treatment program. And it's not an easy process. It is very challenging. And that's why I suggest looking at some that are already, that have thought about it very carefully and planned. And some of these people, I know the Addiction Technology Transfer does do some presentations for those specific programs that receive that funding. And that might be someone to consult with. I think Roy Pack is a part of that from this ATTC, who would be a lot more knowledgeable on the programs that are taking place throughout the country in Indian country.
Yeah.
This is Dr. Foster again, and Roy Pack would be good. And I want to add a little bit. Many prescribers really are not that knowledgeable about addiction medicine. They're not that knowledgeable about addiction. And part of our big problems were that because our prescribers would rather please our clients, our people, than say no. And most of our folks that got addicted, they say, well, I got started when my prescriber. That's not entirely true. Your prescriber never told you to crush and snort, all those exaggeration, all that manipulation. And Indians are no exception. We can manipulate the heck out of our own family, and we do, and we will. And so that's not entirely true about prescribers. And so it's important that prescribers not overprescribe or underprescribe and prescribe within their knowledge. And if they don't have a sufficient knowledge base, they need to add to it. But we also find that people that are the most prone to opioid addiction, for example, are those who don't work, who haven't worked. They're looking for a shortcut. Alcohol is such a wonderful shortcut. Many of us have loved the journey and hated the destination But opioids can be wonderful too, unless you don't mind constipation. And we won't get into all the details and side effects, but there's aspects that just suck. They're horrible for anybody, and everything has outcomes. But it's wonderful when we can do it in a nuanced, informed way. How wonderful to have people, for example, what we've set up, and some of you'll be angry when you hear me, and I go after sexual predators. However, we have many sexual predators that will never be convicted. They're still in the community. We still have to address their addiction. We still have to address their victims. We still have to address those who enable them. And so we've established what we call safe harbor for addictions, for sexual abuse and stuff. So don't misunderstand. We do real strict oversight with folks who step into this safe harbor with regular checks for substance use. For our sexual offenders, we literally even use penile plethysmograph. So we let their privates do the talking rather than their mouth when they see how improving, and we show them different slides and stuff and see which they have a response to. So it's a pretty strict, pretty intrusive oversight for this safe harbor. But we found that people really don't like being violent. They really don't like the compulsive disorder of addiction, whether it's sexual, gambling, substance use, or whatever. And how wonderful for someone who's employed at IHS, for example, to maintain their privacy, to keep their job, and they might be on the alternative medication for the rest of their life. However, we found that when we now we call it discontinuation. I love English. There's so many ways of saying withdraw. But anyway, when we discontinue very, 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 very slowly, we have good success. And so some will combine with the supportive treatment that Dr. Garcia said. Some simply won't. They just are too distrustful. All of us that grew up with secrets, you know that we tend to be liars in the sense of we overpresent that we're doing better than we are. And many of our substance users and so forth have learned from an early age to overpresent healthiness and stuff. And it's wonderful when we can get to a spot of disclosure that's accurate and honest. In all of our languages, we have what we call ikte, real human beings. It's awesome to be real, but sometimes it'll get you 20 years. So sometimes it's good not to be real. Sometimes it's good to kind of keep privacy. Well, thanks for listening, and hope some of these extra comments are useful for you.
Well, Dr. Garcia, we've got about 5 minutes left. Again, I want to thank everyone for attending, and a lot of great comments coming in on the chat, people enjoying this. Again, I'll just reiterate that we will make these available to you. This content and information, this event is recorded, so it will be available at our YouTube archive website, the HTC archive, so it can be viewed along with any other past recorded webinar that Dr. Garcia or Dr. Foster have done and our other consultants in the past. So those will all come to you via email within a couple of days of the ending of this event. I want to thank everyone again. If there are no further questions, we'll go ahead and close. Any final thoughts, Dr. Garcia?
I was just really fascinated with the lady's question on how they could implement, the medication-assisted treatment in their community, and realizing that there's communities out there that haven't even, attempted to provide that service. And I do know the medical professionals that we work with are trained. They have to go through a training before we could even establish the program that we have. And it seems to be working real well for those that follow the program like they should. And like I said, not all of them follow it like they should. We've had situations where we were giving a medication, but not seeing them take it, to find out that they were selling it and giving it away. And we had to reel them in and let them know that that's really serious. It could be a serious offense legally, but we were not there to punish them. We were there to help them. And so they have to reevaluate those behaviors in their life, which is why treatment is so important. And this opioid use disorder has affected this entire country, and even more so during this COVID crisis that we're having. As I tend to look at data around substance use, and it has shown a huge increase in all the types of substances since this has occurred. And I think just this week, it's been a year of this COVID, and we have our numbers are starting to increase in our treatment programming. And it's just an ongoing struggle for a lot of people, and I'm glad that we're able to share this. We need treatment professionals. There aren't a lot of them out there, and so I appreciate everyone who's taken the time today, who has an interest in learning what we have to share, so that it might help you when you're ready to sit for the exam. And here in Wyoming, we have different levels of certification because we don't have a lot of people that attain the master level. So we have, they call them CAPs and CAPAs. So we have addiction professionals and addiction professional assistants. And now we're using the peer specialists, and those peer people are really amazing. They do really good work, and our clients seem to relate really well to them. And as we present all of this information, I see that, more, we'll be probably adding more to this as time goes on. And I encourage you all to attend each session that we have. The first Wednesday of every month, I'll be presenting another segment on these essential skills for substance use. And thank you all for your time today.
Thank you again, Avis, and great to see everyone. Until next time, stay safe, stay connected, and stay healthy. We'll see you again. Signing off.